Zoll has pushed the boundaries of what is possible for 35 years in the tradition of company co-founder Paul Zoll, a Lasker Award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
Good morning, everyone. I'm Chung from South Korea. Thank you very much for this opportunity to join you at this conference. I have no financial conflicts of interest on this subject. What I would like to do today is firstly introduce the Resuscitation Council of Asia and BLS guidelines of RCA, and thereafter I will elaborate on the differences between the RCA guidelines and those of the AHA and ERC. Finally, I will touch briefly on the BLS guidelines of Japan and Korea. The Resuscitation Council of Asia was founded in July 2005. The founding members of RCA include Japan, Korea, Singapore, and Taiwan in alphabetical order. In 2006, the RCA became an official member of ILCO. In 2010 and 2011, the Philippines and Thailand joined the RCA. The Resuscitation Council of Hong Kong and the Penang CPR Society in Malaysia also joined the RCA family as associate members. This is a map of Asia. The member countries of the RCA are located in Eastern and Southern Asia. This graph shows survival outcomes of out-of-hospital cardiac arrest in major Asian cities. The data were collected from Pan-Asian Resuscitation Outcome Study PAROS data. The survival to discharge rate varies from 1.3% in Kuala Lumpur to 8.9% in Seoul. The proportion of good neurologic outcomes, shown in green, ranges from 1.5 to 3%. This is the first time that members of the RCA have worked together to come up with our own BLS guideline for lay rescuers. A task force team co-chaired by Dr. Tetsuya Sakamoto in Japan and Sung-Oh Hwang in Korea has been appointed to formulate the RCA BLS guideline. This is the RCA BLS guideline. You can find the algorithm on the RCA website. The address is resuscitationcouncil.asia. Let's look at in detail. The algorithm starts with verify scene safety, which is the same initial step used by AHA. If a victim is unresponsive, then shout for nearby help and activate the emergency system, get an AED, or follow the dispatcher's instruction, and then check for breathing. If a victim has normal breathing, then continue monitoring and wait for EMS to arrive. If breathing is absent or the rescuer is not sure, then start compression. The algorithm is for laypersons, so we do not recommend the pulse check. Next is chest compression. The hand position is at the lower half of sternum. The chest compression depth was recommended to be approximately 5 cm and no more than 6 cm. The RCA recommends compression-only CPR for lay rescuers. If the rescuer is trained, able, or willing to give rescue breath, then the RCA recommends adding ventilation with a ratio of 30:2. If an AED arrives during compression, attach and analyze the ECG. If shock is indicated, give one shock and resume CPR with compressions immediately. Continue CPR and analyze the ECG every 2 minutes until EMS arrival. The first discussion point is compression depth. The RCA recommends that compression in an adult should be approximately 5 cm, which is the same as the recommendation of ILCO. But AHA and ERC recommend at least 5 cm. As you know, approximately 5 cm includes 4 or 4.5 cm. Avoiding excessive compression of greater than 6 cm is the same for all guidelines. One reason for choosing a compression depth of approximately 5 cm was this study, which analyzed ROC data from more than 9,000 out-of-hospital cardiac arrest patients. The result shows the maximum survival rate was observed at the depth of 4.5 cm with an interval of 4 to 5.5 cm. The authors conclude that the 2010 AHA CPR guideline target for compression depth may be too high. Another reason was the study of Dr. Hasekawa in Japan, which investigated association between body weight and the quality of chest compression performed by Japanese nurses. Most of these Japanese nurses were women, and half of them were in their 20s and 30s. Their average body weight was only 53 kilograms. This graph shows the percentage of adequate compression for each 30-second interval. The adequate compression rate of the heavy group did not significantly decline, but it significantly decreased over time in the light group. Statistical significance was observed between the groups, which differed by 90 seconds. In Asia, a considerable proportion of female doctors or nurses may not be able to compress more than 5 cm, no matter how hard they try, due to their small body weight. Thus, we cannot recommend the compression depth of at least 5 cm. The rationale behind the RCA's recommendation of compression-only CPR is derived from this Japanese study. This graph shows trend in the proportion of each type of CPR training from 2005 to 2012. The proportion of those receiving compression-only CPR increased gradually during the period, but conventional CPR training decreased. When compression-only CPR training increased, good neurologic outcomes of the any CPR group, the black line, increased from 8 to 38%. The red line shows that the compression-only CPR group also increased from 1 to 25%, while there were no significant changes in the conventional CPR group, which is shown in the green line. This study demonstrates that nationwide dissemination of compression-only CPR for layless cures was associated with an increase in the incidence of survivor with favorable neurologic outcomes after out-of-hospital cardiac arrest in Japan. Thus, we recommend this strategy in other Asian countries. In summary, there are two slight differences between the RCA and the international guidelines: emphasis on compression-only CPR and the permissible lower chest compression depth. This is the Japanese BLS algorithm made in last October. The style is same as the RCA algorithm. This is the Korean BLS algorithm for layless cures made this past December. The style is different, but the contents is the same as the RCA algorithm. There are two versions of algorithm, Korean and English version. Translation of international guideline is another complex issue in non-English speaking countries in Asia. We added reference tables to each algorithm as a supplement of simple algorithm, like this. In summary, the RCA made their own BLS guideline for the first time. The RCA guideline emphasized the compression-only CPR and recommend compression depth of approximately 5 cm. We hope that the RCA algorithm helps Asian countries to develop their own CPR guidelines. Thank you very much.